Hello and welcome back to Investigator Insights Emerging Multikinase Inhibitors in Thyroid Carcinoma. Joining me once again is Dr. Marcia Brose from the University of Pennsylvania. So Marcia, let's delve right into some of the multikinase inhibitors. But first, let's go back over the targets. You mentioned BRAF and angiogenesis, as well as the PI3 kinase AKT-mTOR pathway. Tell us a little more specifically about which targets go with which histology and how frequently they are abnormal.
Well, let's talk about the first target, which is actually the fact that these are highly vascular tumors. So the VEGF receptor inhibitors actually target angiogenesis. And that actually works for all thyroid tumors, and it's medullary as well as the differentiated. So that's probably one of the #1 targets that many of these kinases actually do attack. But then the next ones have to do more with what are the different molecular changes that we see inside the tumor cells. So we have two different pathways, as you just mentioned. We have the MAP kinase, BRAF, MEK pathway, and we also have the AKT-mTOR pathway. Those two pathways are very often abnormal in differentiated thyroid cancer. So we tend to try to attack them and wherever we can. So there have been actual studies looking where some of the agents have activity against BRAF, some of them might have activity against MEK, some of them are mTOR inhibitors that are now being studied as well. So those studies are actually still coming out. They're more in the phase 2 world still at this point. Some of the VEGF, or actually most of the VEGF receptor inhibitors, are what we call dirty drugs. In other words, they don't just hit the VEGF receptor, they also hit some of these other ones. The RET kinase, actually, there's a translocation called the RET-PTC translocation, also is a possible target. And since these signal through those same two pathways, hitting BRAF or MEK or any of these other ones can sort of complement whatever antiogenic activity they may also have.
Very good. Well, one of the drugs that seems furthest along in the clinical trial pathway is sorafenib, a drug that was approved a number of years ago for renal cell carcinoma, another highly vascular tumor. And I know that you've been involved in some of the early trials with sorafenib. So take us through that clinical trial pathway, how sorafenib was identified as a potential agent for thyroid carcinomas, and what the phase 1 and phase 2 trials showed leading up to the large phase 3 decision trial.
Yeah, that was a fun story. So for us at Penn, what happened was we actually saw that thyroid cancer was a vascular tumor. In 2003, it became clear that it also had the same BRAF molecular abnormality that the melanomas did. In fact, I had been working as a postdoc in a lab that had been researching some of the melanoma and BRAF abnormalities. And so when we switched over to thyroid cancer and it had the same mutation, we were sort of thinking at Penn, wow, this looks familiar. And interestingly, at that time, they were still studying sorafenib in renal cancer. It hadn't been approved. And what was interesting is they were trying to understand the high blood pressure side effect that went with that drug. And because of that, they opened up for some slots at that time for patients who were not actually renal cell patients. And so we put the first patient on as part of that phase 1. And remarkably, this patient had a wonderful response.
Wow.
And the endocrinologist just jumped out of her seat. She was so excited. And I was thrilled too, because it had taken me quite a bit of time to convince her to let me treat the patient. And so when it worked out, we were like, well, we have to move forward. So then we'd made a phase 2 right away that was to test a single agent sorafenib open label study, and we actually accrued 55 patients to that study. It was so positive that when we did our check for futility, which is a check you do halfway through to make sure that you're not wasting your time, we'd actually already reached our primary endpoint. So in other words, we had already shown that the trial was positive with only half the number of patients because the effect was so good.
So in these trials, I mean, we usually think of some of the targeted agents as more shutting down pathways and stopping growth and stimulating apoptosis. But do you look for actual tumor shrinkage by RECIST criteria, or is progression-free survival more important?
Well, so that's really interesting. I guess it really depends on who you are. If you're a patient who's symptomatic, and I've had a few of these recently who are coughing and miserable because they're short of breath, or they have really severe pain, or they're having trouble swallowing, then the amount that they shrink, it's important. As it turned out, we showed that about a third of our patients, a little less than a third of our patients, will have what we call a PR, meaning they'll shrink at least 30%. And virtually all of the patients shrink some. So it's really quite a very, very good response. I mean, that everybody would get, or 95% of the patients would get some benefit as far as shrinkage. But when you think about the fact that the majority of patients are actually asymptomatic, then what's maybe more important to them is not how much it shrinks, because they won't feel the difference, but how long does it last?
Right.
And so in that study, we actually found that the average amount of time that people took to progress was about 18 months. And so we were really very, very excited about that result.
What about survival? Have any of the studies shown that there is pretty solid evidence of prolongation of survival?
There really is none so far. It's interesting, and it's going to be a hard number to tease out, partly because most of the studies, the way that they're actually structured and designed, they would answer whether or not there's overall survival for a single agent. But since so many agents came on the market or came into phase 2 trials around the same time, patients who failed one agent went on to another agent and another agent. So what I think will happen in the next few years is we hopefully will see an improvement in overall survival, but it will be a class effect. We won't probably be able to say it directly related to one drug or another. However, when the data comes out from the larger studies, the phase 3 studies, maybe they'll be able to get at some of that data. But I think it's going to be a hard number to get at since there's so much crossover. And there's even crossover in those designs as well.
So sorafenib has a known adverse event profile, and patients with renal cell, unfortunately, are not on sorafenib for nearly as long. But after 18 months of sorafenib and thyroid carcinoma, how well tolerated is this agent?
That's a great question, and in fact, it's the topic of an ASCO abstract that we just put in yesterday. So it turns out one of the worst toxicities is the skin toxicity. Right. And for patients who have hepatocellular or renal who are not on the drug very long, it can be a very prominent part of their course. As it turns out, when you have patients who are on it for 18 months with thyroid cancer who are otherwise healthy people, most of those skin toxicities actually peak in the first and second cycle. And by 6 cycles, they've actually resolved mostly to grade 1. So as it turns out, it is a very, very well-tolerated drug if you can manage them through kind of the rough few months up front. The vast majority who had to stop drug or decrease it maybe because of rash problems, they were actually able to restart it back at full dose, or if they decreased their dose, they were able to go back up to full dose. And a small population of also hand-foot syndrome patients were also able to go back up to full dose. And some of them who had to decrease their dose were maintained well at a 3/4 dose and did very well for a long time. But it's an interesting thing because I think it got a little bit of a bad reputation because those patients, many of them went off the drug when they were still sort of in the peak of those toxicities. But if they're well managed, they can actually become down to a grade 1 and tolerable for the duration, the majority of their treatment.
So can you identify the patients most likely to get into trouble with skin rash, fair-complected people or others? And are there any prophylactic measures that you routinely use to try to minimize that side effect?
Yeah, so as far as who gets into trouble, I do think people who've had a lot of sun exposure in their lives can get into a little bit more trouble with skin problems. It's not totally clear who will and who won't. Actually, sometimes I'm quite surprised at the person who seems completely miserable. It may not be the person I would have predicted at all. But with really aggressive treatment with creams, and then we actually use ibuprofen to help with the pain, especially during the kind of crisis period. Many times it can go from a grade 3 or an intolerable grade 2 down to a grade 2 just until it actually subsides on by itself. But this is a very key point, I think, is that many practitioners, if they don't understand that profile, will decrease the dose right away and then not realize that it was going to get better on its own. And so then they won't realize that they might be able to actually increase the dose back again. So that's an important profile for them to understand.
Encourage people to get through it, decrease the dose where it's appropriate, but think about going back
Yeah.
up if things get better.
Yeah,
Very
and
good.
actually we sometimes do holidays instead of decreasing their
Right.
dose. So they don't get into the mindset that they're going to decrease the dose. It turns out a 5-day holiday sometimes can be all they need to kind of really heal whatever part is really hurting them. And then when they go back on that same dose, whether it's full dose or back on the dose they were on before, remarkably, they actually tolerate it much, much better. So sometimes decreasing the dose for us actually is a last resort.
Great. So tell us about the phase 3 decision trial with sorafenib versus placebo. How big is this trial? What do we know about results so far? And was the agent tolerated as well in a very large group as opposed to a 30 to 50 phase 2 population?
Well, so that's an interesting question. So the phase 3 was designed as a randomized placebo-controlled double-blinded trial. So patients were actually put on placebo or put on sorafenib, and no one knew which one they were going to be put on. The tolerability I found was the same as I had expected, previously. I was, for the patients who I suspected were on drug and who later on I found out were on drug, had pretty much the same profile I just described. In the phase 3 actually enrolled 419 patients worldwide. So these are investigators all over Europe, Asia, as well as North America. And really that was a large population. We don't know exactly what the data shows because that hasn't been released yet. We only know from a couple of weeks ago on January 3rd when the press release was released that the progression-free survival endpoint had been met, meaning that the people who were on drug had a significantly longer progression-free survival period than the people who were on placebo. And that was picked to be the primary endpoint because it felt like it was the most clinically relevant for the majority of patients. But what the actual numbers are and how that data looks at this point, we're all waiting to hear.
So is there a crossover allowance for patients who progress on placebo?
Sure, and the treatment scheme actually shows this. So what happens is people are randomized to the placebo or to the treatment group with sorafenib. They're followed using RECIST criteria every 2 months. And this is pretty much what I do in my regular practice. It seems appropriate, at least initially, to follow them at that interval. If they have a growth of more than 20% by RECIST criteria, then they get unblinded and they have the choice. Do they actually want to change their therapy? Now, people who are on sorafenib, sometimes the reason they progress is they might have a single lesion that's causing a problem. If that can be treated, sometimes that will be treated and then the patient would choose to continue therapy. Other people who are on placebo when they were found to be unblinded, then they had the choice, and most of them, I think, at that point chose to cross over to the treatment arm. And then they were followed, and many of them did very, very well. In fact, most of them shrunk to way below the levels that they had been at when they started.
Very good. So when you progress on an agent like sorafenib, a frontline agent, what are the therapeutic options that are available to you, beyond that initial first-line drug?
So I alluded to one, which is right away you want to evaluate the whole patient. So if they progressed, did they progress in one place or did they progress in several places? Because if all of their disease is escaping, you really need to switch agents. But if most of their disease is stable and only one lesion started growing and it's in a place where it can be remedied by either some focal radiation to that point or removal with a quick surgery because it's a lymph node that's near an accessible area, that sometimes is what I choose, because if it's a good agent, I want to sort of use it as long as it's going to work.
Sure.
And then what happens is if that agent really doesn't look like it's working because we have more than one spot that's progressing, what we'll often do is we'll try them on additional agents. So one approach we've used in a phase 2 that's now, it's been accruing very well, is people who've stopped sorafenib, people who progressed on sorafenib. We actually add in an mTOR inhibitor. Now, referring back, remember, to those two pathways we talked about, if sorafenib gets the VEGF receptor inhibitors and also some of the BRAF activity, the other pathway, the AKT-mTOR pathway, is not being shut down. And we had a little bit of suggestion in some of our patients that that might be the escape pathway. In other words, that pathway was being used to avoid the blockage. So since some of the lesions, especially in people who have stable disease on sorafenib, we want to keep the sorafenib going, we add in everolimus. Everolimus is an mTOR inhibitor.
Right.
And we've actually started to see some responses with that, and that data is still accruing. Hopefully that trial will complete soon. But then the other possibility, which most people do, especially if they don't have access to our trial, is they will switch to another agent. And there is some good data that says that if you go to either pazopanib, some patients are actually being treated on another phase 3 that's open right now, the ASI Select trial for lenvatinib. There, in the phase 2 data, there was some data to show that if they had been treated previously on sorafenib or other agents, they still got a benefit. So you can switch to a second line kinase inhibitor, being lenvatinib being the most developed outside of sorafenib, or pazopanib, which also has some very good phase 2 data. And that's what we do quite regularly. So patients sometimes will go through 2 or 3 different kinases while they're being treated.
Very good. Well, let's end this segment, and then we'll go on in the third segment and talk about some of these other agents, the ones directed to VEGFR and mTOR and MEK and the more specific BRAF agents, and see what else is coming down through the pipeline.
Sure.
All right. So thank you very much, Marcia, and thanks to all of you for watching this segment of Investigator Insights, Emerging Multikinase Therapy for Thyroid Carcinoma.